You've heard a lot of really fantastic lectures, kind of giving you different stories about HIV, about Spanish flu. And what you may have started to notice is that there are some commonalities between these stories. So, oh, here we go. There we go. So today I'll be focusing on 5 key lessons learned throughout history, throughout these stories. And these are by no means the only lessons. They're just the lessons that I'll focus on in the interest of time. And I'll also just say that because this is a wrap-up session, the slides and the points that I'm making will draw heavily on material developed by other lecturers. So let's start out with the first lesson, which is the scapegoating tendency. A scapegoat is a person or a group or an entity that is blamed for the wrongdoings, mistakes, or faults of others. And we saw this occurring throughout the many stories that we listened to. And so we know that in acute public health crises, the supply and the demand for information is heightened. And amid many uncertainties, we know that a simple villain can offer psychological comfort. And so we have many examples of this. In the 1918 Spanish flu, there were conspiracy theories that the Germans were spreading poison clouds, conspiracy theories that the German pharmaceutical company Bayer was using infected aspirin to spread the disease. For HIV, we learned about how there are conspiracy theories that it was being spread intentionally as a form of genocide, which we know isn't true. And more recently for COVID-19, we know about conspiracy theories that COVID-19 was created in a lab in Wuhan, China, conspiracy theories that it's being spread by 5G networks. And the 5G networks conspiracy theory was actually so widely accepted that it led to people burning down cell towers in the United Kingdom. And so why does this happen? Essentially, why do we see this reoccurring throughout history? Well, we know that misinformation is often emotionally compelling and engaging. And on the contrary, the truth may be complex and unimaginative. So if we think about COVID-19, we don't know exactly how the novel coronavirus began spreading in humans. We have a pretty good idea. We think that it was transmitted from bats to humans through zoonotic transmission, but we don't exactly know where that happened, when that happened, how that happened. So you can imagine that's not very satisfying. And we know that misinformation about the source of public health crises can erode public trust in institutions. So if you think the government is lying to you about the true source of a public health crisis, then you're less likely to believe other information that the government is telling you. And this could be the government, it could be any other institution or group of people. So what does this tell us? It tells us that expedient and straightforward information from credible sources is really needed to prevent individuals from filling in gaps with misinformation. And that's not to say that conspiracy theories won't still arise if credible information is shared, but really to underscore that a vacuum of information can make individuals even more susceptible to misinformation and disinformation. All right, so let's start with our second lesson, which is that the consequences of withholding information on developing appropriate risk perception. So we all know broadly that behavior change has tangible and intangible costs. We can think through that in just a few practical examples. So if we think about getting vaccinations for yourself or for your children, you have to have the knowledge that you need to get a vaccine. You have to make an appointment to get a vaccination. You have to remember that appointment to get vaccinated. You have to get to the clinic. So that could be driving, that could be taking a bus, which has costs, that could be walking, which takes time. You have to maybe take time off work, that has costs. When you get to the clinic, you have to wait, that has costs. And maybe you even have to pay for the vaccination, that has costs. We can also think through this with COVID-19. So social distancing, guidelines have costs. There are mental effects of social distancing and isolation and not getting to see your friends and your family as much. So if there are all these costs, well, why do we do these things? It's because we think that the benefits outweigh the costs. But without information about the benefits of a behavior change, the costs are no longer justifiable. And so we've seen this related to immunizations. We know that vaccines have saved millions of lives. We know that coverage has been stagnating globally for a decade. And you learned that demand for vaccines is influenced by a variety of different factors, but one of those variables is an individual's knowledge, attitudes, and beliefs about vaccine preventable diseases. And because vaccination has been such a huge public health success, you'll often hear that immunizations are a victim of their own success. And what that really means is that in many areas of the world, you don't typically see a case of paralysis from polio on a day-to-day basis. You don't typically see measles, blindness due to measles every day. You might still see it, of course, but it's not as typical and not as prevalent as it used to be. And that's because the vaccines are working. And so at first glance, it may feel like these diseases are no longer a big threat and that vaccines are not needed. And so we know that's not true, but we also know that if individuals don't have correct information about the risks associated with not getting vaccinated, they're more likely to not get vaccinated. And that's what the results on this slide are also showing. So this is just one example. This is a study conducted among mothers, pregnant mothers. And you can see that there's a correlation between how serious they believe influenza and pertussis are and how likely they believe they are to get vaccinated. So mothers that believe that influenza is not very serious are less likely to get vaccinated, and the same for pertussis. We also saw this happening in the Spanish flu. So at the start of the Spanish flu pandemic, many political and public health leaders downplayed the seriousness of the pandemic. And you learned that some of the reason for that was because of World War I. And political leaders at the time in the United States is one example of how they were still encouraging public events. They didn't let people know how to protect themselves. And even national public health leaders were saying that this is just the ordinary flu. It's just mild influenza, which is what you see on the left-hand side of this slide. But meanwhile, individuals could see all around them that people that were getting infected with the Spanish flu had really gruesome symptoms. And so there was a discordance between what people were being told by their leaders, by their government, by their public health authorities, and what they were actually seeing around them. And so this led to an immense distrust of the government and an unwillingness to believe in other information that came from these leaders. So later in the pandemic, when there was public health guidance that you should wear a mask, this recommendation wasn't taken seriously. And the government instituted mask mandates, but they were met with resistance. And people felt that their constitutional liberties were not being treated fairly, essentially. And unfortunately, this is very eerily similar to what we're seeing today with the COVID-19 pandemic. So this map is from the United States, and it's showing variability in compliance with mask wearing guidelines. And so we know that how concerned an individual is about their own risk for COVID-19 influences their likelihood of using adoptive behaviors, such as wearing a mask. And now I'll take a moment to just pause and say that I realize that this is a massive oversimplification. There are many different factors that influence whether somebody complies with public health guidance. But in some ways, it is very simple. If you tell people that a condition isn't serious, you shouldn't worry about it, it's just the flu, but then you tell them that they have to wear a mask, then it's only natural for people to feel like their individual freedoms and liberties are being violated for no good reason. So what have we learned from this? We learned that downplaying public health risks undermines public trust and reduces the likelihood that guidance will be followed. We know that we don't want to develop messages that are entirely based on fear, but we also know that we have to be honest with the public about risks in order to motivate changes in behavior. All right, our next lesson learned is that compliance with public health recommendations is a function of public trust. So as I just mentioned in the Spanish flu and other examples, willingness to follow public health recommendations depends on the perceived credibility of the individuals and the organizations that are making those recommendations. We do know that over time, public trust in authority and power figures has eroded. You learned about how this is particularly pronounced among young people. And we see this is the case with immunizations. So if you don't trust scientists, doctors, and nurses, you're less likely to trust their recommendations that a vaccine is safe. We see this also with recent outbreaks of Ebola in the Democratic Republic of Congo. So you learned about how there was widespread beliefs that misinformation was a scheme of the government. And we see that having low institutional trust in DRC is associated with a decreased likelihood of attending an Ebola treatment center and also a decreased likelihood of accepting Ebola vaccine. And again, we see it with COVID-19. So the United States is just one example of how distrust in the government influences an individual's likelihood of adhering to government recommended prevention measures. And if you don't trust the government, you also may not trust a vaccine that the government is recommending, that the government is approving of. This leads us to our next lesson, which is that gaining trust is a process and not an end state. So oftentimes, community engagement is only considered in the context of acute public health crises. And we have to acknowledge that even the best community engagement strategy, even the best messages during a public health crisis may have limited utility in dispelling centuries of historical distrust. So I'll pull from another example in the United States. In the United States, Black Americans have faced a long history of systemic racism that impacts their access and quality of healthcare that they can receive in this country. And actually, less than half a century has gone by since the US government terminated some just really horrific experiments called the Tuskegee syphilis study. And that in that study, it involved Black American men who had syphilis, and researchers intentionally withheld available treatment for syphilis because they wanted to know what would happen if treatment wasn't given. So obviously this is horrific, and it resulted, rightly so, in distrust in public health systems and distrust in authority figures in the United States. And so just having a good community engagement strategy during, for example, the COVID-19 pandemic is not sufficient to overcome that long history of just systemic racism. And so we see that with willingness to get a COVID-19 vaccine. So there are still large disparities between Black Americans and white Americans and Black Americans and many other races in this country about willingness to accept a COVID-19 vaccine once it becomes available. So this is just one example of how building trust requires establishing permanent community feedback mechanisms that are tied to concrete action. Cultivating and sustaining public trust has to be done over time and at all times, not just during a pandemic. And you got to see some really cool examples from Eva Erlach. She had her presentation on listening and responding to communities in Africa, and she told us about what IFRC has recently been doing to create action based on community feedback. So she described how they use data about rumors about burials during Ebola to change burial strategies that they were using. They introduced body bags that had windows. And she also described how they built boreholes as part of their COVID-19 response in Cameroon based on community concerns about access to water. This leads us to our final lesson learned. Formulating infection control measures that need to be informed by rather than against culture and context. So we already talked about how the adoption of prevention behaviors is a function of perceived cost and perceived and real costs and benefits. And so one type of cost that's often neglected is whether a prevention recommendation conflicts with cultural or practical realities. And when that occurs, it's not likely that the message will be adhered to, even if an individual has appropriate risk perception. So one example of this is lessons learned from the 2014-2015 Ebola outbreaks in Western Africa, and also the more recent Ebola outbreaks in DRC as well. which is that for many people, providing a traditional burial for their loved ones is more important than avoiding Ebola infection. The problem was not that these people didn't understand they were at risk for contracting Ebola. It's not that they didn't understand that Ebola was a severe disease, but despite understanding all of that, they still felt that a traditional burial for them was a cultural necessity and was more valuable. And another example of this is in the COVID-19 pandemic. So we have all these recommendations that you should stay at home and you should stay distant and you should stay away from others. Well, that's all fine and good if you can do that. But if your job requires you to go into the market or it requires you to go and work into a factory, well, even if you are very afraid of getting COVID-19 infection, you can't follow that guidance because your source of income depends on you breaking that rule. So what does this tell us? It tells us that well-intended public health messages that conflict with cultural values or practical realities are not likely to be followed. And just by trying to stick to this golden rule best practices, we're making our public health messages potentially less effective. So what we should do instead is take information from communities and use that to inform the messages that we're developing. And so information from communities can tell you that individuals are less likely to adhere to recommendations to stop traditional burial practices, but that those practices could be made safer using messages that integrate protective steps into the rituals. So instead of do not touch or wash the body during funerals, something that could potentially be more effective would be if you're burying a loved one, make sure to use gloves. Make sure to wash your hands if you touch the body, etc. And in the same vein, instead of stay at home and avoid crowds, we have to acknowledge the practical realities. So maybe a message like, if you must be in crowded places, use a mask and try to maintain 6 feet of distance. So really, this is a point that was made by many of your lecturers. The recipient of the message must be involved in formulating the message itself. And involving community members in co-creating infection control messages increases the likelihood that messages will be effective. And Karen Greener in her lecture just had a really great example that I loved, which was that, instead of saying, here's the bread, do you like it? Do you want to put jam on it? Instead, we should be saying, can you please come into the kitchen with me? Should we make bread? Should we make chapati instead? Do we even need bread? What do we need? So this brings us to the end. But where do we go from here? We reviewed some examples about predictable ways in which misinformation affects behaviors. And throughout these slides, I've referred to these trends as lessons learned. But really, I'd like to pose that question to you. Have we really learned these lessons if they keep reoccurring over time? And I encourage you to think through other reoccurring themes that you've noticed, and also themes that maybe are specific to the context that you're working in. And you can share these observations in the chat or in your groups that you're working on different challenges with. And just to end with, as infodemic managers, it's up to you to advocate for strategies that incorporate these lessons and prevent history from repeating itself. I do not envy you. It's definitely a difficult task, but I commend you on leading the charge, and I look forward to seeing what you accomplish. Thank you very much for your time.